objective number one, go ahead and start filming if you haven't already. So objective one on your study guide is describe the anatomy of fibrous joints, cartilaginous joints, and synovial joints. So first I'm going to talk about what those are. And here are the, I had told you this in lecture, but we're going to do it here in lab. But in lecture I said, I want you to know the types of joints based on how much they move. You remember that? And if it is a synarthrosis, it's not supposed to move. If the bones in your skull are moving, you got a problem. Okay? If the frontal and the parietal are somehow separating, or you're breaking all those interdigitations, you're ripping all those fibers, that's bad. So synarthrosis is an immovable joint, and the examples they had here were the suture in the skull, or a gomphosis, that's what holds the tooth in its socket, immost. Okay, so we got that. The amphiarthrosis, there's slight movement, and the example they're using is the pubic symphysis. So if you think of your pubic symphysis right here, you probably don't have much movement, but we've got this nice blue. I like this model because it uses different colors for the hyaline cartilage and the fibrocartilage, okay? Well, this is fibrocartilage. It's tough, it's durable, it probably will survive, but if you're trying to pass a baby through that pelvis, you need to be able to do a little bit of movement, okay? That's an example of an amphiarthrosis. I'll give you another one that I don't know if they would agree with this, but I certainly would. This would be a cartilaginous joint that I would say amphi. I'm talking about where the ribs join the sternum. Because I don't know how much memory my phone has, I'm not going to pull up a picture. I'll just tell you guys. Normally I would be going for pull up an article, but every year I'm talking about a little kid doing Little League, gets hit in the chest by a baseball, and there's enough flex right there that there's less in an adult because we have more minerals in the cartilage to stiffen it up. But there's enough flex for a baseball to hit a kid and give him a heart attack. Yeah, and when I was talking about this maybe 5 years ago, one of the kids in our class was a firefighter who had to revive a kid earlier, I think it was earlier that year, but there's a park across the street from wherever his fire station is, and he heard people yelling. There was a kid who had had a heart attack when he got hit in the chest by a baseball, and he had to keep the kid alive until the EMTs got there. So yeah, this totally happens. Talk to me later if you want to know what I think about those stories about Wang Fei Hung being able to stop people's heart with a strike to the chest. Short answer is they were really young back then. I think probably it's true. All right, so cartilaginous joint, fibrous joint, we're building up to that. But we've done immovable joint, slightly movable joint. If it's freely movable, that's a diarthrosis. That's terms based on the amount of movement. And this could be as easy as you walk up to a test question and I say, hey, what's a freely movable joint called? And you'd have to say diarthrosis. Or if I say, what is the joint that moves the least? And you'd have to say synarthrosis. Does that make sense? Things like that. So I do want you to know this. But now we're going to focus on the thing in the study guide where it says, describe the anatomy of a fibrous joint, or cartilaginous joint, or a synovial joint. Well, a fibrous joint has fibers holding the pieces together. The classic example of that is a suture. In your lab book, they have a picture. I'm looking on page 231, I think. Let me put my readers on to make sure of that. There we go. All right. Yeah, picture 231. So all three of these in figure 10.1 are types of fibrous joints. So here we have fibers holding the two plates of the skull together, plates of cranium. Here we have that gomphosis that we talked about in lecture, where we have fibers, part of the periodontal ligament, tying the tooth into the alveolus, into the tooth socket. Everybody good with that? All right. And if you guys don't remember, the reason we call this this, the alveolar margin of the maxilla, all those holes, the tooth sockets, those are alveoli. If you're using this as the alveolar margin of the mandible, same thing. Tooth sockets are alveoli, it just means a sac or a space. Does that make sense? Everybody good? All right, but the teeth are held into those alveoli, those tooth sockets, by periodontal ligaments. Why is this that way? It should be up like that. And we should have more light. It's pissing me off. That might be too much. Is that better? Easier to see? All right, so the gomphosis right there. And here we've got a ligament tying the radius to the ulna, okay? So all of these are, and this ligament they're talking about right here, this is the interosseous ligament, the one that's in the middle there. By the way, remember that, use that. That means between the bones, interosseous. Guess what? When you get to circulatory, we talk about, well, your brachial artery is going to divide up. I have 3 branches here we're going to talk about. The one along the radius will be the radial artery. The one along the ulna will be the ulnar artery. The one that runs down the middle is your interosseous. That won't be hard to remember if you think of the ligament, interosseous ligament. Everybody good? All right, so these terms, we'll see them again. But we've got 3 examples right there of fibrous joints. They all have fibers holding the bones together. Good. Now, cartilaginous joints, if you look at that pubic symphysis, if you look at the intervertebral disc, if you look at where the ribs join the sternum, stuff that we were just talking about, those are all cartilaginous joints. Let's look at some other examples they have. So, types of cartilaginous joints. This is on table 10.3. We have synchondrosis. This is an immovable joint. We're talking about hooking the epiphysis to the diaphysis, okay? We're talking about hooking the ribs to the sternum. And I already told you, I don't think that all of these are immovable. I think it would be better to call them amphiarthrosis because they have a little bit of movement when you're young, at least. Okay, a symphysis is where bones come together. That term is true no matter what. Obviously, the pubic symphysis, cartilaginous joint, just like we were talking about. This right here, where the sides of the mandible come together and then fuse, that is called a mandibular symphysis, and that's bone, that's not cartilage. So just know that symphysis means they're coming together. There's more than one kind of symphysis. Everybody good with that? But just like they're talking, the pubic symphysis absolutely is a cartilaginous joint. Okay? So we've got that. Synovial joints, they have the joint capsule around the outside. And there's a picture of this in your lab book on 233, I think that is. Yeah, 233. Okay, so we have 2 bones, proximal bone, distal bone. Each one has articular cartilage on the end. Articular cartilage is a hyaline cartilage, but it's extra squishy, has more water in it than normal. All right, that cartilage rubbing on cartilage is better than bone on bone. But what's better than that? All this space, this joint capsule is full of synovial fluid that lubricates the bones rubbing on each other. Instead of bone on bone, instead of cartilage on cartilage, you have lubricated cartilage on cartilage. A lot more comfortable. Good? All right, so we've got that. In this picture in your book, I know that in the PowerPoint that I was doing before, they had the synovial membrane in green. Here they have it in purple. Don't worry about the color. The synovial membrane is what's on the side of the joint capsule. Everybody good with that? Side, and what it does is it makes that synovial fluid, it releases synovial fluid into the joint. Good? All right, so parts of a synovial membrane, you have the capsule, you have the synovial membrane. The cavity is the space inside, and it's usually full of synovial fluid unless something bad happened. So we've talked about the anatomy of fibrous cartilaginous synovial. I think that's good. Now, the only other thing here, demonstrate the identity of various body movements. So they have flexion, extension, hyperextension. We're going to go through these: abduction, adduction, circumduction, rotation. There are 2 that are not here. I'm going to write them down. I don't know if they're in here or not. I'm just going to write them down. I want you to know 2 other movements that are not on the study guide. I will be testing on them. So I want you to know supination and pronation. I'll demonstrate them in just a second, but I want you to know those two, and I'm telling you why I want you to know them. Because when we get to muscles, there are muscles named the supinator and the pronator teres that are on your list that you must memorize. Some muscles are named on what motion they cause. That's the example of those two muscles. So it'll be easier if you remember the muscles when you get to them, if you remember what the movements are. So I'm adding these movements even though they're not in the study guide. We'll do them first. Are you ready? Really, really simple. So I'm standing in the anatomical position. You guys agree? Okay. My thumbs are lateral, my palms are to the anterior, my palms are forward. Good. I'm going to raise my arms so it's easier to see. Okay. This is, if I was laying on the ground, we'd say this is laying prone. If you were to move from the prone position with your thumbs here to the position they are when you're in the anatomical position. Let me say it another way. If you were to rotate your thumbs laterally, your palms upward, it's like you're moving your hands so someone could hand you a bowl of soup. This is supination. Good, good. So a movement from here to the anatomical position. Bring the palms forward, the thumbs from medial to lateral. That's supination. The opposite of that, the motion you would need if you're going from anatomical position to having your palms back or downward. Say you're at a crime scene, you're a crime scene investigator, you have to draw a chalk line and somebody's laying like this. They've been shot, they're dead, they're laying like this. We would say that that victim is laying prone, yeah? Well, this movement, bringing the thumbs from lateral to medial, that is pronation. Good? So those are two movements I want you to know that are outside the ones on the list. Good so far? All right. Now I'm going to look for your lab book pretty pictures that I'm sure exist, but if they don't, yeah, they don't. Okay, that's rubbish. We're going to go for your textbook to do these. All right. So articulations. Yeah. So almost all of these motions that you need, there's a handy little table, a figure 9.7, 9.8, 9.10 in your lecture book on pages 306 and 307. Good? All right, so 306, 307. Let's talk about these though. The ones on your study guide they want you to know are flexion, extension, hyperextension. Those are the three for A. So let's discuss what this means. Flexion is any movement that makes the angle get tighter, get narrower. So if I take my leg and I do that, raise my knee up, you would agree the angle between my thigh and my crural region, let me say it another way. If the knee comes up, you just took the angle between the thigh and the lower leg and it got tighter, yes? So this would be flexion, this would be extension, okay? If we do this with the elbow, okay? Flexion, the angle's getting tighter. Extension, angle is getting longer. Do we agree? Now, do me a favor, don't harm me. But you would agree that if you were to grab my hand, pretend, you're not gonna harm me. Yeah, if you did this to me, you could cause me a world of hurt. Do we agree? Yeah. What you'd be doing is trying to hyperextend the elbow. That's possible, but we're probably gonna break some ligaments. It'll not be fun, okay? There are some joints that are fine with hyperextension. So this is flexion of the neck, extension of the neck, hyperextension of the neck. Everybody good? Okay. I can't do it, but people who are really good at yoga and all, they will hyperextend their back to extreme levels, right? Yeah, okay. You were staying close, you saw I cheated, I used my knees because my waist won't do that. But some people will, So this would be flexion at the hip, extension of the hip, hyperextension. Well, it should be, but I can't go beyond that. You got the idea, yes? Okay, so hyperextension would be going past the normal range, okay? But you understand the meaning of flexion and extension. Now, let's take a look at this. The way they describe it right here on figure 9.7 in your textbook, flexion, extension, hyperextension of the head, great. They don't show hyperextension here because they don't want anybody harmed, but you got the elbow, okay? Same thing for the carpal bones, flexion, extension. We'll use that a lot when we name muscles. Also here, your digital extensors are going to do that. Your digital flexors are going to do that. Good? Yep. Now, this is fine. Okay. Knee flexed, knee extended. Knee flexed, knee extended. I don't like it, but they throw all that out the window when they start talking about the ankle. We'll get to that. We'll get to that. But the ankle, they change the name, the way they're naming it, and it upsets me because I would like everything to be said in a manner that was clear and concise and you had no have a problem. But we don't have that. We have what they did. So watch this. You ready? The first one I'm going to do, it makes sense. This is an ankle, okay? And I'm going to bring my toes upward towards my back. This they call dorsiflexion. You agree my toes are going up towards my back and the ankle is flexing, right? Dorsiflexion. Okay. But this should be called extension in my opinion, and they don't. If you point your toes towards the ground, they call that plantar flexion. I don't know why, it doesn't make sense. You just have to memorize it. Plantar flexion. I will give you a way to remember it. Any movement, any direction on the ankle, up or down, we're going to call flexion. And the ones that are towards the ground, like say towards where you are walking on the grass, it's towards the plants. That's plantar flexion. If you don't remember, the bottom of the foot region is plantar anyway. We did that in the first day, remember? But you got it. So dorsiflexion, plantar flexion, you got that. Okay, now, okay, there we go. I'm flipping to 308 at the top. I want to talk about the other ankle movements and get that nonsense out of the way. So we've got the dorsiflexion, plantar flexion, you see that. But the next one, eversion and inversion. I should have stayed up there, but look at my foot. Pretend that I see something on the floor and I'm going to bring it. There's an expensive thing that's fallen on the ground. I'm trying to be sly and not have somebody see it. I'm bringing it back in. That would be inversion. I'm bringing things into the midline. Are you with me? Okay. Now the opposite would be if I try to push things away from my body, like, oh, I don't want the dangerous thing. That'd be eversion. You're trying to move things away. Okay. E like exit. You're getting things away from your body. Good. So inversion, eversion. You guys got that? That's all the ankle movements. So we've got that. All right, now, these, depression and elevation, we're going to use those again. So elevation means you're making things go up. So shoulders up, that's elevation. Shoulders down, that would be depression. Where we're going to use that again, we get to muscles. When we talk about what the temporalis muscle does or the masseter muscle, we are elevate the jaw and depress the jaw. Does that make sense? Both the temporalis and the masseter are going to elevate the jaw. The difference, and you'll get this when we get to muscle, the temporalis, because the fibers are running that way. Let me show you. A lot of it's like diagonal fibers. You got that? So when they pull, the jaw is not just elevated, it's elevated and retracted. So bring it up and back. Does that make sense? Okay. Anyway, the elevation and retraction, you're going to need to know those. Retraction is when you bring the jaw back. Protraction is when you push it forward. Good. Opposition is the opposable thumb. We can take our thumb and go this way, or this way, or this way, or this way. It can be moved to go all the way. Are we good to touch any of those? So we have totally knocked out the table, the figure 911 on the top of 308, 309. Let's see what else we have here. At the top of 9.7, we have done flexion, extension, hyperextension. We haven't done that. Lateral flexion. If you think about someone who is trying to bend this way, say you're doing exercise, this would be moving the torso laterally, move the head to the lateral. This would be lateral flexion of the spine. Everybody good? Yep, okay. So we've got that, we've done that. Circumduction, I want you to think of the word circle, okay? If you take your ankle and move it around like this so you can draw a circle. Say you're holding, I'm not gonna take my shoes off and do this. Pretend you're holding in your toes a marker. If I was to draw a circle on the floor, that movement would be circumduction. Are you with me? If I would do this, I did it in a lecture once last week. This is circumduction of the shoulder. So the first one is circumduction of the hip, the second one is circumduction of the shoulder. What do you need to do circumduction? A ball and socket joint. Good? All right. So that movement's called circumduction. We've done that one. Let's see. We've done flexion, extension, hyperextension. We have not done abduction and adduction. I'm going to go to the bottom here. Look at the legs or the arms. You could move them towards the midline of the body or away. With the thumb, you could move it towards the midline of the hand or away. You see that? So if someone gets kidnapped, we say they are abducted. Good. If we move a leg away from the midline, we have abducted that leg. If we move an arm away from the midline, we've abducted that leg. If we take our thumb, anybody remember the fancy P word for the thumb? The pollex, okay? The little muscle that does this, it's a long, thin, we call that the abductor pollicis longus. That's named that because it's named after what it does. Oh, that's that long muscle that abducts the thumb, abductor pollicis longus. Does that make sense? So abduction is taking something away. Bringing it back is adduction. Okay. So if I was here and I brought my leg back, that would be adduction. Everybody good? Okay. Take your arm and bring it back, that's adduction. So we're good with those. Now the thing that they are not doing here, and I do want to talk about, you heard before flexion and extension. You will see later on, I can grab the old lab book to do it actually. There's an example of that is messed up. Don't be surprised, I already talked about how I don't like the idea of plantar flexion when it's clearly extension. But raising the arm like this, some people, and the old textbook was one of them, describe this movement as flexion. And you're like, huh? It's because they're not working on the joints we're thinking of. Okay, I'm going to draw for you a person. We have a head, we have a torso, we have a shoulder, we have an arm. I'm a great artist. Okay. So here we have an arm. If you raise this like that, I would normally have thought the arm coming up, you're increasing this angle. I would have called this extension. That's not the angle that they are talking about. When people say that this is flexion of the arm, we're flexing the arm, what they're talking about is this angle between the neck and the arm. That's totally, I don't know why, it doesn't make a bit of sense to me. But the reason they call this flexion is because you have the angle between the clavicle, the neck, and the arm gets narrower, so they call it flexion. Does that make sense? Just know that people get tripped up by that because it's done badly, made badly. So would you agree, we've done flexion, extension, hyperextension, we have done abduction, adduction, yes? We have done circumduction, do you agree? The only thing left here on the objectives is D, which is rotation, medial and lateral. So, ankle, I'm going to bring my toes towards the midline. This would be medial rotation, this would be lateral rotation. That's not hard, medial rotation, lateral rotation. Here, hand, same thing. I could rotate my hand this way, that would be a medial rotation, that would be a lateral rotation. You with me? Make sense? Okay. Let's check the tables here and see if there's anything we haven't done. We've done abduction, abduction, rotational movement. Yeah, so lateral and medial rotation, what I just demonstrated, figure 910, page 307, bottom of 307. Do you agree we've gone over all of this, yes? Okay, stop the recording.